Scenario 1. Gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of malignea. On examination, she was tachycardic and hypotensive at 121 beats per minute and 90/50 millimeters per mercury respectively. She manifests parlor with no icterus. She is epenemic and normothermic but reports intermediate periumbilical tenderness. Medication history reveals occasional take of a non-steroidal anti-inflammatory drug naproxen, 250 milligrams, for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1 grams per deciliter, hemocratic of 32%, prolonged prothrombin time, and a positive Gugwinic test. All other laboratory studies were within normal limits. Based on these clinical presentations, intravenous fluids were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal endoscopy was performed, which revealed a 1x1 hemorrhagic gastric ulcer. The bleeding ulcer was categorized and biopsies were taken for Helicobacter pylori, the results of which are negative. Proton pump inhibitors were started and she was discharged after 2 days in stable condition. Scenario 2. Uncontrolled non-insulin dependent diabetes mellitus. A 58-year-old female was rushed to A 58-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation in both feet and occasional blurred vision. The client admits to problems adhering to her prescribed dietary and medication regimen. She doesn't exercise regularly, takes her medications only when she is reminded, and doesn't watch her diet. She denies dyspnea, polydysplasia, polyuria, and diaphoresis. The client had a history of non-insulin dependent diabetes mellitus for 15 years and dyslipidemia and hypertension for 8 years. She had laser photocoagulation for retinopathy in the past year. She is on metformin and glipizide for control of hyperglycemia and hydrochloride and ramapil as antihypertensives and autovastin for hyperlipidemia. Upon examination, her blood pressure is 185/98 millimeters per mercury. Fasting blood glucose is 260 milligrams per deciliter. Hemoglobin A1C is 9%. Serum blood urea, nitrogen and creatine at 53 milligrams per deciliter and 4.4 milligrams per deciliter, respectively. Urinalysis and 24-hour urine collection uncovered trace proteins in urinary albumin excretion rate of 255 milligrams per day, leading to a diagnosis of microalbuminemia. Nerve condition studies, the electromyography confirmed diabetic neuropathy, decreased visual acuity, and new extensive reticule vascular growth were revealed through the ophthalmic exam. Based on the client's typical presentations, the final medication impression and diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated by hypertension, dyslipidemia, neuropathy, retinopathy, and microalbuminemia.